about the commission or reports of the past meetings, please visit SMCHD, St. Mary's County Health Department, SMCHD. We always are thankful to St. Mary's County for posting the website .org/COPH, Commission on Public Health. Reminding everybody, this is a public meeting. We have followed the requirements of posting or notification of this meeting. This meeting is being video recorded. By your continued participation in this meeting, you consent to the video recording. We ask members of the public who may be attending to use their microphones online during this session. This meeting does not, I repeat, does not include a time frame of the comment and will not be monitoring the chat function during the meeting. However, we do encourage public comments to be sent to us via email to md.coph@maryland.gov. md.coph@maryland.gov. We also ask members of the commission to mute your microphones when not speaking. Please use the raise hand function to indicate that you wish to speak and you will be recognized. Individuals who serve on the commission are subject to Maryland public ethics law. All have confirmed their agreement to this in their application and listed any conflicts of interest. There are attendance requirements for individuals appointed by the governor, and these are from state government code. And I will not now ask Michelle to conduct a roll call of the commissioners. Michelle, if you would.
Give me 1 second. Yeah.
Okay.
Chittibim, do you have the list?
For roll call. Just 1 second as we get our list together.
Hi, this is Rosalie Bright. In the meantime, since you said you're not monitoring chat and I reported audio difficulties with hearing people in the room in the chat, so now I'm raising my hand and interrupting. But in any case, I'm catching about every other word of what's being said in the room, and I'd like that to be improved. Thanks.
Work on that. Thank you for the feedback. When I call your name, please say present or here. Heather Bagnall.
Here.
Boris Lushniak.
Here.
Camille Blake Fall. Nina Brewster.
Here.
Jean Drummond.
Yes.
Nilesh Kalyana Raman.
Here.
Alyssa Lord. Alawatosin Alateju. Fran Phillips.
Here.
Nicole Rochester. Mara Rossman.
Present.
Michelle Spencer.
Here.
Alan Twigg.
Here.
Okay, thank you.
Great, thank you. We have 9 commissioners present, and that does give us a quorum for the 50% plus 1. The agenda has been posted and distributed to the commissioners. Any comments on the agenda as it currently stands? And if there are none, I ask for a motion to approve today's agenda. Second. All for approving the agenda, say aye. Or raise your hand.
Aye.
Anyone against? Anyone abstaining? The agenda has been approved. What's that? Sorry. Mean to move friends. We also have minutes from the previous meeting that's been posted. The meeting took place on August 1st, were posted and distributed. Any comments on the minutes as posted on the website? If there are no comments, I ask for a motion to approve the minutes. Okay, Fran moved. Who second? Mina seconds. All for approving the August minutes, say aye.
Aye.
Any against? Any against online? Yell out. Any abstentions? Okay, so the minutes have been approved. Our next component of the agenda here today is our guest. We are very excited to have Chad Furman here. I'm going to ask Mina to introduce him to our group. We're also eager not only to have him tell us about the Maryland Department of Health Office of Primary Care, but obviously for the commissioners to engage in a vibrant discussion about this and how it applies to our commission's work. Please, Mina.
Well, we're really excited to have you here, Chad. Thank you so much. So Chad Furman is the Executive Director of the Maryland Primary Care Program Management Office since 2021. He was previously with that program as Program Director as well. He has a significant history of having co-designed an innovative advanced primary care program with CMS from during that 2016-2017 time period, and now oversees Maryland's partnership with CMS and is focused on the kind of the integration or the connection between primary care and the public health system overall. He's really been a key member of Maryland Department of Health team when it comes to the guidance on the primary care system here in Maryland and how we can continue to advance primary care in the state. Previously, he's served as Director of Health Systems Transformation within MDH's Office of Population Health Improvement, and prior to that was a consultant in health insurance. We're really glad to have you here. Thank you so much. And eager to hear your talk. We've had much conversation at this commission about the role of primary care and connection.
Thank you very much.
Might be better for the audience that they can hear you.
Yeah, it'll be
If that's
probably
okay.
better just so we have, I hate podiums myself, but I think just for the audio component.
Good thing I've been practicing.
And online, are we hearing any better when we're speaking at the microphone? So Chad is going to give us a few test words. Chad?
This is Chad. Can you hear me?
Okay, we're getting thumbs up. So I hope our technical issue has been resolved, and thank you for that notification.
Perfect. Thank you guys for having me. I'm really excited. So many familiar faces. Appreciate the commission having me. Lots of updates to provide today on the development of the Maryland Primary Care Program, but also the intersection with public health, population health, and opportunities to really improve that. So I'm going to bring you up to speed on all those things. Let me, where we are, just a level set on the program, where the overlaps that I see are today with public health, and some of the accomplishments of the program as it relates to public health, and then where there are opportunities going further. We're really looking forward to hearing from you and taking questions, but also understanding where you see the opportunities going forward. So with that, we'll jump into it. So the program, just as a reminder, this is a statewide primary care program. The idea is that it is part of building a comprehensive system-wide, statewide primary care program that supports population health. And you can't do that without focus both on the prevention side as well as management. So let me talk a little bit about where we are in terms of the program. So this is the largest advanced primary care program in the nation for the Medicare fee-for-service population. Of course, practices take care of a much broader population than just the Medicare population, but given the Maryland model that we have here today in terms of healthcare transformation, the focus was to start with the Medicare population. Maryland, despite its size, has the largest program in the nation. I'll show you a few more tidbits on that in a moment. We're in the 6th year of the program. We started in 2019, and the program serves in the neighborhood probably of 4 million Marylanders when you think about all the patients that are in these practices. It's about a $200 million program of federal dollars that are going directly into primary care every year. We've been very fortunate to be able to have this agreement with CMS and have them making this investment in our primary care. And as all of you know, and we'll talk a little bit about it, we're talking about a new model for Maryland, and CMS has been very clear that the foundation to that has to be primary care. It has to be Medicaid primary care as well. So we're working on developing that. There's really a lot of opportunity to address the needs of the entire population. So as I mentioned, as the largest Medicare Advanced primary care program, the chart on the left shows you the number of practices. So just in terms of sheer number of practices, not adjusted for size of population, the program is the largest in the country. When you look at the chart on the right, even if you look at it per 100,000 state residents, we're over 8, which is more than double the next state. So while advanced primary care is not the only way that we want to provide access to care, it is a higher level of care that we want to focus on for our community. Reminder of where we are. So we have an agreement with CMS called the Maryland Total Cost of Care Model. One of the key components of that is the Maryland Primary Care Program. We have global budgets is also another piece of that, as well as some care redesign programs, as well as the SciHIS population health, which I'll talk a little bit about as well. But just gives you a sense of where we are in terms of the program, how is a key component today, and how it's going to become more of a focus going forward, particularly as we're trying to address health equity and population health. So in terms of the program size and where we are, 511 practices across the state. That's almost 600 sites because we have FQHCs in the program as well, where they have multiple sites, serving about 360,000 Medicare beneficiaries who are officially part of the program. Remember, these practices are taking care of the entire population. So what they do well for a Medicare population often translates what they do for other patients as well. You can see the distribution on the map here. It looks pretty much similar to what the concentration of the population is, but the important piece is that we have practices that are in every part of the state, even the smallest counties with the least number of population. Practices are in this program, meaning they've committed to being part of something that's larger than just their practice. We have care transformation organizations I'll talk a little more about. These are organizations that are privately run that are helping practices do this work. As we think about driving population health, the practices have to be part of that role. So we've established care requirements in the program. And those care requirements are around providing these 5 areas or 5 functions. So access and continuity. So we're talking about alternative care like telehealth. We're talking about expanded hours, care management, risk stratified care management, identifying patients with the greatest needs who can benefit from additional resources. Comprehensive care. So the program requires integration of behavioral health as well as addressing social needs and linkages to care. Beneficiary and caregiver experience. So there's a particular focus on advanced care planning as well as getting feedback and driving care based on what patients need in the practice. And then the population health approach that's driven by data. And I'll talk a little more about where data fits into the program. So just in terms of tracks of the program, I won't bore you on this. We started with a track 1 and track 2, entry level track and an advanced track. Track 1 is now sunsetted as of 23. We have required practices to make that progression to provide higher level capabilities in their practice. So we now offer a track 2 and now a track 3. Track 2 includes everything that we expected the practices in track 1, which are some of those care delivery requirements I just talked about. Track 3 is the next level of that, which includes taking on downside financial risk. You can see the evolution of the practices moving in this slide. So the gray here is track 1, the orange is track 2. So starting in 2019, we had 380 practices in the program, and we had mostly those practices in track 1. Each year, as you'll see, it progressed all the way into 2022. Those were 500 practices were largely in track 2. And then we started offering track 3 in 2023. So now we have a division of practices between those two. And even there you see progression because we continue to require practices to move up and move all the way up to track 3. So about half the practices are in track 2 and track 3 now. As I mentioned, we have CTOs or care transformation organizations that support practices to provide economies of scale, both in terms of staffing, but also data expertise and other transformation supports. 75% of the practices work with a CTO. That number really hasn't changed over the course of the program. And you can see that there's about 250,000 beneficiaries of those 360 that are working with a practice that is supported by a CTO. Practice size, just want to give you a sense of with the types of practices we have in the program, given that it's statewide. The median number of providers in a practice is around 4, and that really has not changed over the course of the program. So you can see that small providers, onesies, twosies, are almost the majority of the program. So it's not just a program that's designed for large organizations. We have a lot of large organizations with large practices, with large organizations with small practices that they're supporting as well. But the majority of practices, particularly in the rural areas, as you know, are much smaller operations. And that's where the support of the program, both from the state, but also from the federal resources, is really important. The other piece I just wanted to share with you is the underserved categories. We've taken a look at practices to see where they are, and particularly when it comes to health professional shortage areas. And you can see almost half of the practices are in either a mental health or primary care HPSA. We have practices that fit the rural county definition as well, largely in the program, and then as well as medically underserved areas. So it's a pretty diverse program. It's not just a program for Central Maryland. I think many of you know we have the CIHIS, or Statewide Integrated Health Improvement Strategy, which is one of the agreements and requirements of the CMS Total Cost of Care model, and we have a population health approach for the state. MDPCP has worked hard to align itself to those measures and to the 3 areas, which is hospital quality, care transformation, and total population health. The one area that I want to kind of flag here is the population health piece. So there's a lot of focus on diabetes. We've done a fair amount of work in terms of getting practices focused on both management of diabetes, but also prevention, focus on DPPs and other programs like that. But the place where we probably have made the most progress is on the substance use side. I'll talk a little more about that later, but the goal of improving overdose mortality has to start right in the community. So we want that capacity built into our primary care practices. So we require practices to integrate behavioral health, but most practices, when they hear that, they think mental health. We can't require practices to do substance use, but about 340 practices in the program have now implemented SBIRT, screening, brief intervention, referral for treatment, and we've now moved into a phase where we're implementing MOUD practices as well. So practices actually prescribing for patients who need that service. In terms of payer alignment for the program, as I said, this program was conceived as a Medicare program with an impact on all payers. CareFirst, and as of 2020, aligned as a aligned payer, meaning they operate their own PCMH that most practices in the state are in. But we work with them to develop similar goals and also shared support. So they have, for example, we have a coaching team at the state. Our coaching team works with the coaching team that goes out into the practices on the CareFirst side and tries to talk about and work on the same things. So, for example, we've focused a lot on diabetes and diabetes quality metrics, sharing the same message and trying to help practices on that. In 2025, we expect Medicaid to come into the program as also an aligned payer. We're still working through all those details. That's going to be done under the new model. But the anticipation is by next summer, we'll have a Medicaid program for the MCO population, the health choice population. And that's should be developed pretty soon this fall, and then we'll be working to get that up and running. The eventual goal here is to have a fully aligned Medicare and Medicaid approach for primary care practices. My office, the Program Management Office, or the MDPCP Management Office, has been in place since 2017, Fran, something like that. So we've been supporting the program, supporting practices. We help run the program with CMS as a joint program. So we do some of the administration, we do technical assistance through our coaching team, and contracted vendors. And we also just provide infrastructure supports. So in other places in the country where they have primary care programs that are run through CMS demonstrations, the practices participate in a program with the feds, and they just operate and they try to meet the program goals. In Maryland, we've made a concentrated effort to have a support through the state to make sure that it's meeting the state's goals, but also to provide those additional supports, because just because you put the financial incentives in front of the practices, it doesn't necessarily bring advanced primary care to your neighborhood. The other piece that we do is we focused on developing work streams that are specific to the state's needs and state's goals. So my office has a health equity work stream, has a public health integration work stream, has an analysis team, and also a behavioral health integration suite. So all those pieces are part of what you see here that the state offers to support practices in this program, in addition to the care transformation organizations that I already mentioned. Just briefly, in terms of success to date in the program has been successful in reducing utilization and costs for the population in Medicare. So per 1,000 beneficiaries, we've seen significant drops in PQIs, or avoidable utilization, emergency department utilization, and inpatient hospitalization. All of the rates for MDPCP are lower than the rates for the non-MDPCP population. We've also seen a lower growth in cost as well. So as you know, with the overall model in the state, we have to meet certain Medicare savings targets. So the program needs to be successful in helping that savings target by slowing the growth of cost for the Medicare population as well. Okay, well, let's talk a little bit about where at least we see sort of the overlaps with public health, and would welcome thoughts as I go through this and as we finish as well. We've done a number of things over the last few years, but the thing we're maybe the proudest of is the public health emergency response that our office contributed to, and that the primary care practices contributed to. So what we're calling now a respiratory disease response, as we move away from the COVID world only, originally started as a COVID response. So we have developed through our coaches and through the program, through leadership that my office has led, has a relationship with 500 plus practices around the state, with 26 care transformation organizations, which includes private organizations that are hospital affiliated and non-hospital affiliated. So through that, we've used our influence and provided resources to these practices, guides, resources, and templates. As related to COVID, we put in play what we call the triple play strategy, which was testing, treatment, and vaccination. The largest, as far as we're aware, the largest primary care vaccination program in the country that went through primary care, right? Remember, vaccinations for COVID was largely only done through hospitals, health departments, and major sites. We had over 500 practices in the state, including over 300 in MDPCP who participated in that work. We have biweekly email updates that go out to primary care practices in the program, but also practices throughout the state, pediatrics as well, that are getting updates on the latest and greatest in terms of COVID vaccines, but other respiratory threats. We have TA that's coming from our staff, both through our coaches as well as through our staff who have developed some expertise in this area. Now we're working on a project with a company called bioMaryU, which is putting testing machines, diagnostic testing machines into practices around the state. We have about 25 machines that we can put out through a federal CDC grant that we got. We're essentially trying to distribute testing machines for diagnosis of COVID, flu A, flu B, and a few other respiratory diseases now. So there can be testing, and these machines are complete, provide feedback, I think it's in 15 minutes. So the idea is that you could have a differential diagnosis and immediately treat your patient if the treatment is available without them leaving at that point. The other thing I want to mention is, so specific to COVID-19, we had a study here that you see. This was published in JAMA a few years ago. This was a comparative analysis to the non-MDPCP population, but you can see these are real impacts. Not only do we have higher vaccination rates, but I think the most important number here is the lower death rate, 27% lower death rate for MDPCP beneficiaries. This is all risk adjusted. So The only reason that could have happened is because these practices were more attuned to that, which is what the state has supported them in doing. And that's really an opportunity for us going forward because we have a relationship with all of these practices to keep them informed and as part of the public health response. Health equity, I can't go without mentioning that. As I mentioned, we have a health equity specific work stream and a lead for that area. There's several folks actually on that team now. So the places where we help practices are a couple. We have data, we provide them claims-based reports that are broken out into different demographics so they can understand. Remember, for many practices, the idea of health equity is this concept that's out there. We're showing them the actual data so they're aware of what's happening in their population. What are the differential rates based on race, sex, age, etc. We provide technical assistance and we require practices to implement social needs screening universally and then connect patients to linkages in the community. We've started to do some quality improvement work for practices, specifically around the HARP payment. So the other piece of this is that we actually have a payment incentive for practices to focus on addressing the social needs of their patients. So CMS and the state came up with something called the HARP payment. It's a health equity advancement payment. And practices are receiving specific monies to focus on the social needs of their patients. Because data has shown, as all of you know, there's a significant differential in the total cost of care for these patients who have high area deprivation index scores based on where they live, and who have high utilization rates already. So we'll talk a little more about that, but that's something that there isn't in any other part of the country. So we're really focusing on practices on how do you use those monies? How does a practice and a CTO support it and focus on using those kind of funds to be specifically enhanced on those areas? So let me say a little more about the HARP payment. This is usually where we end up talking a lot about. So it's $110 PMPM for this, which is a lot of money. It's a lot more than we provide in the program just in general for care management. But that's essentially what the literature has shown, that that's the differential in terms of total cost of care for these patients who are in under-resourced areas and have high needs. So we look at medical complexity, area deprivation index. The practices get lists of these beneficiaries, and they get these additional funds prospectively to then focus on those patients. And as you can see here on the right, it's allowed practices to do a lot of really innovative things. That's what we're excited about. And while they can do these innovative things, partnering with local co-ops to provide food security, helping patients get to appointments, stair rails, that kind of stuff, some of that's only limited, and it can only be sustainable if we have real partnerships in the community, particularly with public health. So I think there's lots of opportunity when it comes to the HARP payment and where that eventually goes. Population health data for primary care, right? So practices have limited abilities to, particularly for those onesie, twosie practices, to do lots of data crunching and then figure out what they can do in between all of their clinical visits. So we've developed a suite of tools for the practices and program that CTOs help with, but also practices have invested in people who are focused on this kind of data. So there's population health tools, there's claims-based reports that we provide them. There's the vaccine tracker. We help the practices give them their list of beneficiaries. They know every beneficiary, which vaccines they've had through the tracker that's powered by CRISP. We provide the point of care tools, many of the tools that CRISP has today as the HIE, including the encounter notification alerts as the patient hit the hospital, the ED, have they been transferred, et cetera. Clinical reporting tools. So we have tools for practices to report their quality measures. They report their quality measures to the state. So we have eyes on it. And then it goes to CMS for the official scoring. We also even have reporting around ESPER for the SUD work. And then finally, we built some prediction tools with the Hilltop Institute that help predict avoidable utilization and a few other events, help practices focus their care management efforts. I mentioned behavioral health integration earlier. A few slides on this. This slide is focused on the mental health side. But as you can see in the pie chart on the left here, in blue is the collaborative care model, which is a model built out of the University of Washington that allows practices to have a care manager in-house, but works with an outside consulting psychiatrist where there's an exchange of data. It's a validated model. We have a lot of practices using that. We also have practices using what they call the behaviorist model, where you actually have somebody on site who's trained in behavioral health care, and then a variety of other pieces. But all the practices have an approach to taking care of mental health needs. As you can see on the right bar chart, practices are largely either annually or every visit are screening for mental health needs. On the substance use side, I called out a little of this before, but 64% of our practices have implemented the SBIRT process. And they're reporting data through CRISP, so we have an idea of their progress, and we can provide assistance to them through a contractor. And we're now over 1 million screenings since 2021. The data only goes back to 21 that we have, but you can see the number of positive screenings and brief interventions that are taking place. And now we're focused on putting medication for opioid use disorder in place as well. So what's next? As I think about it, there are a couple big things that are coming up. We have this AHEAD model, the new model that the federal government has awarded to the state and a few other states that they want us to move to. It's essentially Maryland model, but with a broader, even more of a actual all-payer focus, particularly with a Medicaid focus. So we really want to have an aligned approach for Medicare and Medicaid, and that's what MDH is working on now in developing CMS. But I think the bigger opportunity, right, is how do we really develop long-term active partnerships with the community, with public health entities, et cetera, that really support all of what practices are focusing on. But sometimes there's only so much they can do when it comes to focusing on physical, behavioral, and social needs. They need partners to do this, and I think there's lots of opportunity going forward. Questions?
Great, thank you so much, Chad. Great presentation. I'll open up the floor here initially, internally here to this, and then we'll switch to online, and then we'll go back and forth as necessary. This is a very great presentation. I think, part of it is, as sort of alluded to our questions, is this idea of, first of all, the expansion of your program, right? And the opportunities as well as the challenges that bring. But also, as you mentioned at the end, about next steps, it's the idea of public health entities, right? And how do you incorporate them? I think this is the golden opportunity for us to also delve into this concept of, at the end of all this, we have to come up with recommendations, right? Recommendations to the legislature and the governor to say, here's the path forward on public health. And I would like to also, for us in this discussion now, to focus on this idea of what is the potential, right, of these public health entities, and how do we continue to partner with you to make sure that we, in essence, have a path forward. Well, please, Jean.
Absolutely. Thank you so much, Chad. I've always been so excited about the program. I'm really excited about the new Medicaid alignment that you're speaking of in 2025. Can you share a little bit about that? And then is the health equity work stream, is that something that you could share with us later? I can go on with that.
Sure. So the Medicaid alignment is probably going to happen in 2 phases. I think the first phase is going to be we're going to start with the practices that are already in MDPCP that have already committed to doing this work. I think there's probably going to be some kind of cutoff in terms of what we start with in terms of size of the practices, but it's going to be for the health choice enrollees, right? There's over 1 million of them in Maryland that we'll focus on. And it's going to be done in partnership with the MCOs. So the MCOs will operate primary care programs, will operate with a single set of primary care objectives, but they will still handle payments and still sort of do the management. We're still figuring out exactly how the care management is going to work between the practice and the managed care organization and the CTO. But the idea is that would start up in July of 25, and then would probably start as a 6-month program, and then we'd move into calendar years. So by 26, we'd be going on a calendar year basis. And then in a few years, probably by 27, when AHEAD is fully ramped up, practices will be required to participate in both if they want to be in MDPCP. And we think practices will want to stay in MDPCP. We think practices will want to be part of the Medicaid piece as well. But the requirement is going to be absolutely to participate in Medicaid first. So that's the thinking. And then the model for AHEAD is that it's like a 9.5-year model to take us through 2034.
All right. So many questions came out of that, but we can talk later. Is there the health equity work stream? That is something that is available? See,
I don't know if it's available to see it. You know, we have a health equity manager on my team,
okay.
and she has a team that supports her, and we develop technical assistance. And I think you know Emily on the team that runs that.
Oh, Emily, yeah.
Yeah.
Okay.
So that's the health equity work stream. We're a small but mighty group.
Got it, got it, okay.
Yeah.
So much great presentation.
Yeah.
Great, whole other questions, I'll come back. to
I'll-
you if you have
I'll-
others.
I'll
Okay,
stop.
Mina here.
Great, thank you very much. And I'm particularly keen on the topics of public health integration and public behavioral health integration. So on the topic of behavioral health integration, I appreciate what you were sharing about the perception of mental health, but really it's been from an implementation perspective, it's been mostly about aspirin and medication now for OUD. How about what's the potential for future expansion in that substance use world and the addiction world as well beyond OUD? Are there plans there?
Well, there,
How's that?
yeah, I think there's potential. So the work we've done is in partnership with a contractor that's supported under the State Opioid Response Grant. So all that is run through the Behavioral Health Administration. So we work closely with them. What we're trying to figure out as the next step is where are the practices vis-a-vis the hub and spoke system that they have, and how can we sort of integrate that approach? So that's where it's been on the substance use side. There's certainly opportunity, I think, to go beyond medication for opioid use disorder. On the other hand, we still have a lot of practices who say those patients aren't in my practice, or I don't want those patients in my practice. So there's so much stigma to get past, just that we've done effort slowly to get people past that, and now we're slowly trying to get past the stigma around MOUD.
Because there's alcohol and there's a whole slew of what falls underneath addiction as well beyond.
Well, you're exactly right, and it should be clear. So the ESPER work does include alcohol as well.
And then my follow-up question, public health integration piece. When you were talking about public health integration and the engagement of public health entities, what does that look like? And when you say public health entities, I assume you're included within that. For example, local health department. What kind of entities is participated by this program? How and the local health departments at community level, many of us are already engaging with our primary care practices in various ways. So we have care coordination programs, direct services where we do a lot of connection with our primary care system, programs, etc. What other additional type of engagement? What does that be? Public health integration.
So so I think it's building on what already exists, particularly with local health departments, and coordinating that work. The area where I think the biggest challenge we see, where there's a lot of need, is in the area of social needs. And we've tried building tools through CRISP. Everybody's doing it a little different way. Everybody's got a different screening tool. And what we find a lot with the practices is there might be an organization, whether it's the health department or a community-based organization in their backyard, they don't even know who they are. So those partnerships are pretty limited from our experience. Or there's a partnership, they find one organization they like to work with, and that's kind of it. And you've been working on this for a long time. So there is an essential clearinghouse for handling everybody's social needs and making that a really easy thing to do. And I don't expect it to become easy, but it seems like there's an opportunity there to make it easier.
Great, Brian.
Chad, it's great to see you again for this development. I've got a quick observation and then a question for you. The observation is I think I'm probably one of the few Medicare beneficiaries in the room or in the audience at large. And so I
I
have a
just
little.
joined that elitist.
Okay, good.
Yeah,
Yeah,
it's my son,
oh,
so
you're gonna love it, of course. You're gonna
I'm
love it.
in with you.
Yeah, you know, especially with this advanced part. So I have a little bit about my longtime primary care practice. And I had occasion, I rarely go because I'm healthy, but I go from time to time with a bee sting or a twisted ankle. And I've noticed in the last couple of years that when I go in with a rolled ankle, I get care, that's great. But I also get questions like, how many days in the past month have you felt suicidal? Or I'll get a question like, do you think about falling frequently? And in other words, I get questions that I think are right out of the Chad Perman book, okay? Because and this is not a hit on you, but this is a practice that is vigilant in trying to cover all the bases, including reminding me that I didn't get an RSV, vaccine this year. So you can just, from a patient experience point of view, it feels a little different. And I don't honestly know if it's a care first, could be care first, or could be care both. I don't know what's up. But I do feel like there's more attention to front office patient experience, things like getting a referral, getting a prescription refilled. I don't know if those are any of the kinds of softer skills that practices can improve on, I'll say. But anyway, I do think of you when I get some of those questions. So here's the thing. Nina asked one of the key questions, I think, which is, what does this engagement future, what could it look like? And it's really, I think, a roadmap for us to develop in some ways. To put together the expertise in local health departments, with your coaches, with the MCOs, with the CTOs, with hospital population health units. I mean, it's a whole ecosystem now that is working to support clinical practice by bringing in behavioral health or social referrals to make a much more holistic approach. So I'll leave Venus, and here's my question. You're developing much more effective primary care practices around the state. Problem is we need more primary care practices, right? So you're talking about quality, which is not here on that, but the quantity isn't there, particularly in terms of the distribution. So I don't know if you all are leveraging that in any way, or have some thoughts about how to expand overall.
Well, we're doing a small bit on that right now, I can share, which is we have a new program that's being developed called Equip PC. So under the care redesign component of the model, the state has some flexibility, right, to administer programs for physicians that aligns them with the model goals. So the program called Equip Episode Quality Improvement Program is a bundled care program for specialists largely. We have some extra savings, long story, but that we can put towards primary care. And so the HSCRC developed this idea, which now MDH is going to implement, which is to run this program called Equip Primary Care. And the idea is to build new primary care in the state. So we're going to fund $19 million of practices over the next couple of years in that program. The application's just closed. We had a lot of applications. They're going to be in specific zip codes around the state, based on largely on HPSAs and area deprivation index. But the truth is that's going to be a small drop in the bucket. We're probably talking 5 to 10 practices around the state, right? If you want to fully fund the practice, get them seed funding, get them started for a couple of years, and then make them part of this ecosystem of advanced primary care. The other thing we've been looking at, I don't think there's a strategy here, but you're getting at the question about workforce. And so I think we're starting to look at what does the residency turnover look like, and can we improve that? Can we get more people to choose primary care, but can we get more people who choose primary care to stay in Maryland or come to Maryland? We think programs like Equip PC and MDPCP might help attract, but of course that pipeline is going to take several years.
We do have a question on Rosalie, you're on.
Hi, Chad. So I was heartened to hear that you have a pretty strong program for COVID that you're converting into a respiratory diseases program. There's one element that I didn't hear about or see in your slides, and I think is also very important, and that's in focusing on air quality and respirator use. And the more practices make sure to clean their air, tell their patients they're cleaning their air, encourage respirator use among the staff and the patients, I think you're going to see results in the health outcomes of these patients. And they'll take that philosophy, that philosophy will spill over to other kinds of practices besides primary care and other kind of settings besides healthcare for the patient. So I would really encourage doing something like that, especially since we're seeing lower vaccinations for airborne diseases like measles and TB and other kinds of really serious airborne pathogens. Thank you.
Thanks, Rosalie. Great comment.
Great. Here in the room, we have Jean, has a question. Jean, please.
Thank you very much, Chad. That was a wonderful presentation. I'm sort of piggybacking on what Fran has said, and I wanted to go to the CTOs because I feel you said 75% of practices will use the CTOs support, and that their functions are both in staffing and data management and predictions to help the decision makers. Do you see any way in which the CTO infrastructure could partner with help of local counties in order to really have that bilateral communication of what's happening in the local area, and also coordination in terms of staffing and workforce development?
Yeah, I mean, I think that would be ideal. I know there's been different iterations, but I think under AHEAD and some population health planning, there's talk about having regional planning groups, and I would imagine the CTOs could be a really good contributor to that, right? So there could be talk about who are social needs partners in the community, who are behavioral health partners. How do we coordinate for this particular relation? I think absolutely, and I think there's a lot of CTOs. I think in some worlds maybe we don't need to have that many, but on the other hand, practices have different needs and they have different partners that they want to work with. And so if you have a community that's filled with a variety of CTOs who are doing different things, I think they can be really effective. They can really voice the needs of the practices who don't have time to do that, right? And they're just, are smaller in organization size. But they can also bring the fore, they can sort of serve as a liaison between the practices and the local plan.
Great. And also online, we have Laura has raised a hand. Laura.
Yeah, hi, Chad. Thank you so much for this presentation. As you're talking, I'm wondering if you could talk about, I envision what I see here as a three-legged stool: public health, primary care offices, and hospital, with one goal is to keep people out of the hospital at, reducing healthcare costs, which are highest, generally speaking, in the hospital. So I'm wondering about what efforts are being done to deliver more healthcare in the home. You mentioned, I think, telehealth, but what about expanded services that primary care providers have another option other than just sending someone to our crowded ERs and hospitals? For example, there may be patients who have pneumonia that can be safely treated at home with home care services, visiting nurse service, etc. So I'm wondering if you and HSCRC or whoever is exploring those options again as sort of the more downstream effects, the more downstream efforts to keep people out of the hospital and reduce hospital costs. Thank you.
Thank you, Maura. It's been something on the list. I can't say it's been a focus over the last few years. Practices have the flexibility to do primary care in-home care. Some of them do that. Some of them, there are a few practices I can think of where that's actually their core business. They provide primary care in the home. But to your point, there's other ways to do this, and there's some places where you would want more of that. I know there's been development of, for example, EMS models, right, where you go to the home and take care of some of those needs. So there's also, recently there was announced an innovation called the AIM, the department at HSCRC are asking for judges, and then they're going to be asked, they're essentially a contest for innovative approaches. And that's probably a perfect place for that. So I could get some more information on that for the group as well, because I think that's probably where we need to go as we think about the next phase of this.
Yeah, and there are other states who, again, it's not just, it's really in between primary care in hospitals. In other words, you have IV treatment, oxygen, et cetera, being delivered at home rather than in the hospital. So thank you.
Chad, I have a question, and really sort of deals with sort of the philosophy and the concept of primary care, and then the interplay between primary care and public health, preventive models, et cetera, et cetera. And the skeptic will say is primary care docs are too busy just taking care of sick people. And so trying to get all this done is not a possibility. Based upon your experience, how do you answer the skeptics?
They are too busy. The only way we're going to be able to expand the ability of taking care of people in the community, though, particularly in the primary care setting, is by putting more resources in it. So that's what NDPCP does. That's what NASM has put out needs to be done. So it's really that team approach, right? It's a multidisciplinary team approach. That's where most of the funds in the program go towards, which is hiring a social worker, nutritionist, et cetera, sharing them through a CTO, social workers in addition. So I think that's the long-term approach, but is it sustainable right now? No, because we haven't committed enough to moving in that direction. We're inching, but we haven't committed long-term to do that.
So I'll be honest, that in essence was a leading question, because the follow-up to that is, as you're speaking with this commission, how can we help in this mission? Right? And again, this is a public meeting, so I don't want you to overstep your bounds of comfort here, but the reality is, what should we be looking at as a commission? A year from now, there's going to be already the final stages of a report that's being issued. If in fact this concept of public health entities, right, working along with primary care and somehow building in is to become a model for the rest of the nation. The beauty of this commission is we do have this enthusiasm because we think that this is really a great honor to be here, but also a great opportunity. So what should we be looking at? Yeah. Yeah.
Just, more directly, if you look at the example of a community where a local health department could be partnering, right? And you have that integration between primary care and public health. To build on Boris's question, what capabilities do we need to build in our public health entities so that they can fully realize this integration that you're talking about here? And of course, part of it is your system and your office having a solid understanding of what already is going on locally. And I'll volunteer our help. We would love to have you come down to St. Mary's County and see some of the work that we've been doing that complements the primary care delivery system. But I think it's good for us to have that discussion. What are some core things, capabilities that health departments need to have around the state so that we can better realize this vision integration?
Well, so just initial thoughts, because great question, hard question. From what I see, and remember, my office is meant to provide technical assistance and facilitate these connections. We're not building the infrastructure itself, and a lot of it's already there. The problem is, from what we see, practices are very focused on their list of patients. They don't know what's happening in the practice next to them, even though it could be helping them. They don't know if their patient could be going there. They don't know if their patient is interacting with the health department. So creating some rules around shared understanding and data exchange, I think are really important. We have a lot of data tools, particularly through CRISP, but there aren't really rules of the road in terms of how do you share that data, how do you talk through it, how do you identify what your patient needs that's available throughout the system, right? It's one practice with a team that's trying to think through clinically from their clinical approach, what do they really need? But without a whole group of partners around the table doing that planning, I don't think we can really realize the vision that we talked about. The other piece I would say is just workforce. We have an opportunity, I think, to build out a long-term system of public health and population health, whatever term you like to use for it, where at least on the primary care side, so from my side, which is we can drive a pipeline of providers and multidisciplinary support staff into this model long-term if they knew what was in it for them. But that message isn't out there. And largely what we see in every state is that there's huge shortage of primary care physicians, nurses, care managers, et cetera. So we haven't optimized the workforce we have by coordinating that, but we also don't have a way for that to work out long term. But if we put the goal in front of them and say, we're going to fund primary care forever, and it's going to be part of a public health system that's broader than that, and here's your role in it. And I think it changes where people go. And I think we need that staffing, we need that workforce to do that. Right now, we have a lot of practices who are doing it at MPCP, but to your point, there's a lot of people who don't have access to primary care at all. So people, and we're not seeing new practices where shingles are going up to do this anymore, because it's not clear that there's a sustainable solution where you don't have to work 20 hours a day and then you're going to make enough money to cover it.
Fran made some excellent points earlier about the workforce just there, right? To fund this to support the realization of that what you just made, which are beautiful, which I think we all want to see all over the place. But I think that begs the question of, and I realize this isn't within the timelines of your office, but it certainly is relevant to your meeting here. That begs the question: what are we doing with GME, graduate medical education, and dollars to support that? And how are those training programs located so that we have access in rural areas, just like we have access in Maryland? Because there hasn't been a lot of the things. We have a new family medicine residency program at Veris Health in Washington County, which is great. It's the first rural family medicine program in the state, but clearly that's not addressing the needs around the state either. So there's a lot of need there. There's the role of AHECs in our state area health education centers as well. That's how are we engaging those entities? They're created to support pipelines, not just of physicians and nurse practitioners, but the multi-D components of our delivery system. And so how can we bolster their role and make sure that what they're doing is translating to that pipeline number? And then, of course, there's other strategies as well. But I think, we absolutely need to have this larger conversation of making sure that units are being built over time and local academics and so forth to realize.
Great. Any final questions here? Yes, Matt.
Thank you for this great presentation. So you talk about care transformation organizations as part of the infrastructure, and one of the challenges that we have in public health is steady funding to create sustainability. We run a lot of programs and grants, and it becomes a kind of keep catching up to where we try to be. Health departments, some of them do really well in care coordination, getting people to those services, but they're excluded, from understanding, from the CTO and CTO model as a function of the head model. And is there an appetite, or is that a possibility to start to bring public health and healthcare closer together by creating that opportunity to create both sustainability and a link to the other social needs of the community through the public health system? Is that something that has been talked about or thought about, or is it even like on the radar whatsoever?
I think we've talked about it and then it's gone as the program has gotten off the ground. I think it's something we certainly could revisit. Personally, I think it's something we should take a look at. Beyond that, there hasn't been, a formal discussion about what that might look like.
I think there's opportunities for the healthcare infrastructure and funding sources to help support the relevant components of public health that allow healthcare to do what they do best, and linking people back to the public health system so that they can thrive in community versus constantly going. And I know the model is to try to move people towards value and health and back to health. And I think the public health infrastructure is poised in a way that would support that. It's a question of how to fuse those together, and partly a question of funding streams.
Great, thank you, Matt. Yes, Brent?
On CTOs, I don't understand, are they private nonprofit entities with boards of directors? Or what is the governance and what's the funds? Where do they get their money from?
So yes, to your question about governance, they'll have to have a governance
They're
structure.
501c3s.
Yeah, I mean, but they don't have to be 501c3s. A lot of them are, because a lot of them are hospital-run organizations, but some of them are for-profit organizations. But there are lots of rules around using the monies because they're Medicare dollars. So the monies they can't just be put in their pocket. They have to be used for the Medicare beneficiary. They have to report on those use of those funds. So they are the dollars that are allocated to the practices based on the different funding streams, which are largely based on the medical complexity, right, of their patients. Those dollars, a portion of them are shared to pay the CTOs to provide services to support them.
So Medicare either directly or through the practice funds.
The practice elects how much they want, who they want to work with, and how much they want to share on a voluntary basis. Not all of them have to work with them. And then Medicare pays them directly based on that allocation.
Okay. Got it, I guess. Thank you.
Well, thank you. Since we're talking a little bit more about CTOs, I was going to talk to you offline. So the CTOs, you mentioned you have a small staff. So the CTOs, what's the range of their staff sizes? Because I'm thinking from a local health department perspective, the CTOs, they have the claims data for the people who are right in our county, and we have shared objectives there between what the CTO, I guess, is if they're doing data analysis for practices. We do have shared objectives. So I'm wondering, do they have a lot of staff, or are they epidemiologists, data analysts, or are they just sort of doing their best like many health departments are doing because they don't necessarily have funding for the epidemiologists in a sense?
I can share.
Do you want to share, Jean?
So I'm CTO. So healthcare data. So just the history, we've done work with CMS for years. And I've always done all that I could to be a forerunner with CMS to stay abreast of their transformation, right? And so we did work after MACRA came out. We did work under the TCPI program, which really positioned us to understand, as a clinician as well, to understand this particular program. So I applied. I think I'm the only small business that is one of the CTOs. So we're probably the smallest of the group because they're hospital systems, but we have a practice that we work with. We have a community health worker that is assigned to that practice that helps them to look at their risk data, that helps wherever they are in need from their HEDIS measures or instead of things here, we can she manages that team. And so it's a small team. So, but it's very customized because there's the funding stream, the practice can decide how much they want us to work with them, how much they want to give of those dollars. I don't know all the details. But it's very customized to help the practice where they see the need. And so it's typically working to get the members and patients in. We did a food market. We actually did a clinical food market because the practice that we're in, the food market is in 7-Eleven around the corner. And he has a lot, the year that I remember, the first year, he had like 40% of his members were dual eligible. And so we just had a lot of challenges. So food was an issue. And so we developed a clinical food pantry where he can literally give out food prescriptions. That was one of the things that we did. So it's hard. So it's really customized. They go from for-profits to non-profits to hospitals. And it's really about what the doctors want. We help them to submit their reports to CMS, admit reports and quarterly reports. So that kind of give you a little bit more, it's technical assistance, and it's really whatever practice needs to help them. And
Yeah, I mean, Jane runs a pretty small shop because she only has a few practices and so, but then there are the hospital system, there are hospital systems. There's also accountable care organizations that have pretty good teams. They're doing a lot of data analysis. The practices are also have the data as well. So some practices, they take that on themselves and really dig into it, but a lot of CTOs help. So it runs the gamut in terms of size of staff, in terms of sophistication as well.
It's not a lot of money. I lost that for sure. We did it only because I'm committed to this work and want to stay on the edge of it, going. So that's why I did it. It wasn't a business decision. I'm passionate about this work.
Yeah, there really is a small amount.
But back to what Dr. was saying, I really think that because especially I believe that the health departments have got cut so much that I could see where with speeding up could be the health departments could be used in that. I don't know how the funding would go with it, but the conversation.
Yeah, if there ever is an annual meeting of the CTOs, if they're ever all put together, we'd love for the health departments to, if there's a portion of it.
You know what? I'm sorry. You're right. So Chad has coaches, and those coaches, we get emails. They call us. They help. So he does have that team. That's how the state really is very helpful in these, I don't know, monthly, quarterly meetings. So there is a lot of resources in Chad's office. I'll tell.
No, I wish we had an annual meeting of the CTOs. We do a monthly meeting with the CTOs where it's mostly operational, but an annual meeting, what you're talking about is something different, which is sort of like, what's the vision here? What's the long-term approach? And with COVID, we stopped doing our annual meetings, but we're hoping to start those.
As Fran just stated, that there's a recommendation there already.
We just,
There you go.
Yeah, so thank you for
you
this.
still have still have the physician, the large groups, remember you said that, the physician groups, bring the physicians in and
Maybe at the conference we did.
okay.
Yeah, we're gonna try to get back to the conference, but we put a stop to that one.
I was getting ready to say you haven't had a.
Yeah, so we do annual trainings for the staff, for advanced primary care staff. We do that virtually. We had it in person. Everyone wants it virtual now, especially since COVID. But instead of focusing on the providers, we focus on all the staff, the multidisciplinary staff, as well as the administrative staff, to help build that education with them. We do that annually for them, but that's once a year, 3 hours, 4 hours maybe. We have an annual conference. We talked about getting back to that. It hasn't happened, but I think there's opportunity for that. I do have coaches, but I have 7 coaches for 508 practices. They work with the CT plus 26 CTOs. So they're spread pretty thin, but it's better than not having any coaches. And I think, it does help the participants get an understanding of where we can support them, where their partners can support them, and help, and just guiding it through the requirements of the program. We try not, they're not clinical coaches. I have coaches who have clinical backgrounds, but we don't go in there and talk to people about how they should be treating diabetes or hypertension. It's about what are the requirements of the program. How do you use data from CRIS, for example? How can we get you engaged in expert development, et cetera?
Great. Well, let's all give a hearty thank you for that. Great presentation, but also best of all was the discussion and the questions afterwards. Today is one of those days where when we get to the latter part, especially of our meeting of our first deep dive, this is exactly what we as commissioners and as members of our teams need to be doing, right? Which is in essence questioning, not putting people on the spot, but inspiring, right? This concept of where the heck are we going to go with all this great information given to us? Because that's going to be our responsibility. So, Chad, thank you for inspiring us today.
Thank you for having me.
Okay, we'll go back to our agenda item, and the next agenda item is the commission updates. And we have Shane Hatchett, who's joining us online. Shane, who's been a very important member of our team and a lead on many different aspects of where we've been heading. We couldn't really be existing without people like Shane and others who have come from the CDC Foundation and in essence been able to support us. So with that lead in, Shane, please take it away.
All right. Thank you, Boris. I have a fair bit of content to cover, so I'm going to breeze through some of this, but please stop me where you have questions if I don't cover something that you want to talk about. As we have been doing at our meetings, this is just the updated timeline where we are in terms of the different activities and our work streams with the assessment, system engagement, and public engagement activities. I'll cover this a little bit more later, but excited to share that we have finally secured the date with Baltimore City Health Department. So a little more information on that to come. But we clearly have shifted our phases from really this kind of information seeking and discussion portion to how do we actually synthesize and break down what we've discovered so far through these deep dives. And we'll continue to do that until we shift to more of the recommendation building work that occurs early next year. It scares me at the same time that it also excites me that we're almost to 2025. So starting to include that calendar on this update as well. Next slide. Oh no, my formatting is not working. I will send this out separately, but I wanted to call to everyone's attention the dates that we originally shared back at the May meeting for the 2025 meeting dates. So with the update from the legislature that allowed us to continue this work until October, we plotted out what the dates would look like. And the most important thing here to make sure that we are aware of is that because of the way that the legislation requires us to have public comment periods for some of the drafts, as well as some of the work that has to occur in between those meetings, these dates don't always fall on that first Thursday, particularly around holiday times like January, for example, where we have New Year's as well as MLK and a few other things that kind of get in the way of that. So we'll make sure that the calendar updates are, or excuse me, the calendar holds are updated and that's on your radar as well. If there are issues or major concerns, please let us know and we'll see what we can do to kind of adapt and make sure that we are addressing those concerns. But at least for now, we're not envisioning any sort of change in terms of the format of meeting at the Prince George's County office building with the hybrid option. Appreciate the feedback around the technology, and we'll continue to refine that and see what we can do to make that a little bit more accessible for folks. Thank you. So shifting gears just a little bit, wanted to make sure that we are really kind of mindful of really all of these different work streams related to the assessment that is underway. And so we've been so heavily focused on the work that our partners at UMD and Morgan State and other academic groups have been doing that I thought it was ideal for us to go back to some of those earlier slides that we shared back in the spring about all the different things that go into our assessment. And so important to remember that the assessment includes not only the work that we're doing through our informant interviews, focus groups, and the organizational survey, but also all the activities that the work groups are doing, for example. So you'll see today through the governance and organizational capabilities deep dive that there's a fair bit of analysis that's already occurred, a fair bit of information collection, as well as leveraging what we have through national and regional data sets such as PHWinds, and of course our site visits and public listening sessions, as well as the public survey that we've been working with the communications and public engagement group to get out for the general public to be able to respond to. So as we're working through what gets included in different instruments in terms of questions and how those are structured, how those are structured, I don't want folks to think that there is not an opportunity to kind of keep that in play or that there aren't other forums for that to be brought up. And so, we can continue to have conversations about how we best place different questions or gather certain pieces of information to make sure that we're still hitting ultimately that deadline of getting our most of our assessment activities done by really the February timeframe of next year, so that our work groups have ample time to process, incorporate that into their recommendations, and of course, ultimately for us to be able to craft our final report and get that through that process. We'll continue to refine this and update it as it does get changed, but certainly wanted to at least put that out there and start to share that idea that, you know, there are several aspects to our assessment framework that come together to really form this comprehensive public health system assessment that we're working on. Next slide. In that vein, we do have some regular touch points with the assessment team. We're meeting at least bi-weekly with them and adding additional meetings as needed. So certainly if you are curious about something or have some feedback that you'd like to share, please do share that with Dashanka, myself, or Sarah Bora, or your work group coordinator. We are happy to make sure that that gets over to them. And then we're also keeping the executive team updated on what's happening there, as well as taking various decision items to them to weigh in on. As I mentioned, we are continuing to refine these questions and responding to the feedback that we got from co-chairs and other commissioners related to some of those questions. I will be very transparent and say, you know, we're really at this point of, there's a lot of great work that's been put into those questions, and the questions certainly are meaningful. The challenge is balancing the pragmatic piece of, we only have so much time that we can spend with folks in the interview. And as we've timed it right now, half of the interview is spent asking just the questions. So it doesn't really leave much time for us to be able to really probe and dig in deeply to some of the content that we're looking to get from the people being interviewed. So Sarah Bora has reached out to all of the work group co-chairs as of today, asking if they could prioritize the questions that their work groups have put together, really focusing kind of on those STEM questions for the respective areas, so that we can make sure that we are able to focus in on the most important pieces. And if there is more time, you know, certainly addressing those. But, you know, the reality is we're really balancing between that fidelity to the task that the statute has set out, as well as, you know, what the commission has asked us to do and to prioritize, but also understanding, you know, there's an element of feasibility here. So you know, just be mindful of that, that if you're hearing no from us, or you feel like we're saying no a lot, that's really what it is. It's not that we don't value or respect what has been put forth, but really just an issue of trying to make sure that we're able to deliver on all of these different pieces. Next slide. Yep. So really want to begin talking about our final interim report that really is right around the corner. I shared at the last meeting that our, you know, approach would be to pull together a draft of this with work group input, and we're working on getting some templates together for work groups to help provide information related to that. But as we were talking at the executive meeting yesterday, it was brought up that, you know, maybe we ought to think about having an additional meeting in November specifically to focus on making sure we've got enough time to digest the draft and get the draft in a place that folks feel comfortable with. So as of now, the current timeline that we're proposing, or had proposed previously, is having folks get everything in by the 21st from the work groups. The support staff would take that and develop a draft of the final report in advance of the November 7th meeting and share that information with the commission at least a week prior. And that at the November 7th meeting, we would be discussing essentially that and focusing on that report, knowing that there would be modifications that come out of that. And so whatever was adopted that day would be, you know, as modified, and the staff would go back and make those updates and ensure it was submitted to the legislature by the December 1st deadline set by the statute. What we wanted to bring up and ask for input on today is, do we need to schedule another meeting, potentially around middle or third week of November to provide ample time for folks to really be able to sit with that. And so I will kind of open it up at this point for feedback on that, but that is essentially what we had wanted to make sure we spent some time talking about today.
So any feelings from the commissioners regarding adding on? I know November, it's the usual holiday time. We already have a meeting on November 7th. Question is, to some extent, when we issue this final interim report, which again has been put in the change of legislation, we do want to, we're going to have to sort of go through the process of making sure that everyone is comfortable with that report. We do have to put it on as a motion in front of this group with the usual Robert's Rules of Orders of supporting a second, et cetera, et cetera. The question, of course, is that at the November 7th meeting, we already have a meeting agenda. We can certainly fit it in there. Things may not be fully done at the November 7th meeting. And by our December meeting, that's already beyond the time limit. I think that the bigger issue is going to be if we decide to go through with an additional, not a full necessarily 3-hour meeting, but a shorter meeting just to focus on this report. It is still going to be a matter of timing and making sure we make it into people's schedules. So any strong feelings from the commissioners, first of all, present here in the room, anything that you feel?
I personally feel like it will be helpful to have a date etched out as an option, so that if the discussion on the 7th warrants another discussion, we already have a date and that serve that purpose. And if we decide on the 7th, we don't need it, then we don't stand it.
Okay, so
About a shorter virtual meeting to finalize adoption of the report gives, it'll be a little easier on the staff and there's another touch.
okay, so in essence, it's proposing a placeholder date in November and that we're later on in November, and with the idea that it's not necessary based upon our discussions about the report at the November 7th meeting that we can erase that. Any feelings strongly here in the room? Yeah,
I
Fran?
don't have a strong feeling, and I think Venus suggestion makes sense, but I guess without knowing the template, without knowing what is the work groups, beyond what they're developing these dives, it's hard for me to actually visualize what the structures look like, and therefore, there's 2 weeks between October 1st when work group reports are going to be done, and 2 weeks to the time for us to adopt it. And I guess, that 2 weeks time as turnaround time to share across the whole commission. And really prep ourselves to be able to adopt. I don't know how controversial, how vanilla, I just don't know. It might be just fine. Vote to approve on done. And without knowing, I think the content of what's going to be expected from each work group, which is the meat of what we're going to be looking at, it's hard to know how long it's going to take for a group to come to something.
Okay.
I mean, so that's a long way of saying I concur with me.
Yeah.
Let's wait and see.
Great. Delegate back now.
I was just gonna say I agree with Fran. I will say though it is easier to schedule a meeting and cancel it than to try and schedule a meeting if we decide that we need it.
Okay. Good. I as chair am in agreement with that. The question is, we need to vote on this. Okay, there's a motion to basically schedule in a meeting in sometime in November after the November 7th meeting, and then hold that as a placeholder. Do you have a second for that motion? Second. All the commissioners who agree with this, please vote, say aye, or raise your hands online.
Aye.
Aye.
Okay. Any against? Okay, Tosin, you raised the hand. Was that a hand for the vote or a hand for a comment?
And for the votes, aye.
Okay, thank you. Okay, so we will, Shane, let's go ahead and try to determine a November meeting virtually to be able to discuss the final interim report. And then if it won't be necessary, we'll schedule that off the books at the November 7th meetings. That sounds good to you, Shane?
It sure does. I've got one more slide here and then I'm done. So thanks for coordinating that. Last thing to share with you, as I alluded to earlier, and some of you have probably seen in your email already, we were able to get the Baltimore City site visit and listening session scheduled. That will be Monday, October 28th. They have secured a venue and at least at this point in time are planning to have some local elected officials attend, and I think they're pretty excited about the opportunity. So we'll be finalizing some more of those details next Tuesday with them. But if you haven't yet, please RSVP. Let me know if you've not received that form. I will resend it to you. But I think we've got a pretty good turnout so far in terms of RSVPs. I do know that that's also during the APHA annual meeting. So for those of you who will be at that instead, we'll certainly miss you, but I understand the challenge.
Great, thank you for that update, Shane. Any questions for Shane? Great work to you and the rest of the team. So thank you so much, Shane. We'll now take our break and let's limit it to a 10-minute break and we'll regroup here at 15 minutes to the hour and then we'll start our deep dive. So a 10-minute break here just for us to socialize a little bit. We once again thank the Prince George's County Health Department for not only hosting us here in this beautiful setting, but also providing some nutrition and some hydration. So thank you so much, Matt, for being here. So anyhow, 10-minute break, folks. And for those of you online, do use your phones and let's be back at 1:45 and we'll begin our deep dive. Thank you. Yeah, that'll work. Yeah, it's fine. Close.
Say it again, sorry. I'm so sorry, Mina. Because the volume.
Well, welcome back, everybody. It's time for the second part of our meeting, and this is a very exciting part of the meeting from a historical aspect, right? We've done a lot of discussion here. We've done a lot of presentations here. We're now beginning to sort of go into this next phase, right? So it's not that we've learned everything. We've certainly tapped into it, and we'll continue to still have speakers coming in to make sure we get those gaps of knowledge and the ability for us as commissioners to learn about what's going on in many different facets that interplay with public health at the state level. But today is the first time that we're really doing, we discussed a while ago about a deep dive from a specific work group. And it's my pleasure to welcome both Fran Phillips and Barbara Brookmeyer from the Governance and Organizational Capabilities Working Group. Now, we realize that you as working group co-chairs have done an incredible amount of work, but I'm sure this also stems from the incredible working group and the activists and volunteers who are part of that group. The concept of a deep dive is actually one of those concepts that we're starting with today. We will modify the process as we see. So this is an experiment today. You aren't being graded, either of you, nor is your working group being graded. Ultimately, what we ask the working groups is look at and present to the commission the bigger features, right, of what you've done to this point in time, but also what are the issues that we need to be discussing here as a commission, and where do we need to be going, right, when it comes to each of the working groups. So this is the first of several months now of activity in this realm. So from the commissioner's perspective, really this is a test also of us in our thought process. So this isn't just a discussion from working group telling us, okay, this is what we've done, this is what we're thinking. But it really now demands us as commissioners to begin asking those questions, to begin probing, and to begin looking at how does this all fit in ultimately into the bigger picture of what we're trying to achieve here. So without further delay, let's begin the process of a deep dive. Now, I'm a diver. Before diving, you always do certain things. There's a safety check, right? You always go with a buddy. You never go alone. You realize that you have to have a certain amount of air in the tank. It's got to be a full tank. That all your equipment is working, that you're relaxed and not stressed. And then you take something called oftentimes the big step off the back of a boat. And you pummel into this water and you come bobbing to the surface. You regain your composure, and then you let the air out of your buoyancy control device and you start floating into an incredible world of beauty, of weightlessness. You are a visitor in an incredible land. And now, using that metaphor, is I am ready to be a visitor in the incredible land of governance and organization capabilities. Fran, no pressure, take it away.
Of course. That was hysterical. So yeah, so no pressure. Just my notes here. This presentation needs to be. You started out saying it's historical, and then you said it's experimental. Then you said it's a test. And then you said, just relax, damn it. Okay, so we'll do our best. As far as a buddy, I do have a buddy, and that's my co-chair, Barbara Brookmeyer, and we are partners in crime here. So we're happy to go first with this deep dive. And we recognize that this is where we are on the producing end. We are no longer passive spectators, not that any of us have ever been passive spectators, but we are not receiving, we are now producing. We are creating for all of you to critique, and I think that's the key point that we do hope, despite the hybrid nature of the meeting, that we have interaction with all of you. The point here is that we're not going to have a report that has 5 chapters and none of them speak to each other, right? Our thinking really needs over time to get aligned, and so that's where we really do. Barbara and I want your feedback as far as questions, comments, what makes sense, what's your critical thinking. And trust me, we'll do the same for you, okay, when it's your turn. And we also see some opportunities in this presentation to call out some of the work groups where we think there's a real overlap between what we're going to talk about with regard to governance and what some of the other work groups have been working on. So as we get to those topics, we will call that out. Okay, so as Barr said, our work group is governance and organizational capabilities. That's a mouthful. And it's the nature of governance is such that we all know it's important. We all know it's essential, but it's kind of tough to define. It's rather amorphous. There's lots of definitions of organizational governance. I've got one that is pretty plain English, which I'll share with you. Organizational governance, how power is distributed and shared in an organization, how policies are formulated, priorities set, and stakeholders made accountable. So, I mean, there's just a lot of various ways to think about governance, but it is pretty subjective. And I'll say compared to, like, contrast the topic area of IT and data or workforce or funding, these are more concrete, I think easier to get your arms around, easier to characterize in terms of quantitative measures than is governance. Now, maybe I'm doing a little whining here, but I know that our work group spent a lot of time, January, February, and some of the early meetings, trying to get our arms around what is the border of our scope, what is our work group's mission really to focus on. And I think part of that is the nature of governance is, as I said, kind of amorphous. We do feel governance has everything to do with relationships between people, with behaviors that people exert in an organization. And for that reason, we are putting tremendous credence on the forthcoming findings of the assessment. As you all know, the assessment has the opportunity to elicit from key informants and from stakeholders, in other words, from people that are interviewed, some of their thinking on qualitative aspects of their agency. And so we really do appreciate the work that has been invested already in designing an assessment that will get at some of these nuances, which are super important, because downstream, we think from governance, downstream flows a lot of what we see as the structures and policies determining workforce or funding communications or data IT. Okay, enough of all that. Okay, so let's plow through it. So what you're going to see here, these slides. All right, these are the slides. If you, in your work groups, have taken a look at the template that was given to us, you're going to pretty much recognize it, but we've done some twists, as we'll show you. The most notable of which is item number 2. On this slide, you're going to see that we've defined our scope of inquiry to look at the key aspects of Maryland's ecosystem of public health. And that's important because we want to capture some of the unique assets that we have in Maryland and how to leverage them to advance state and local public health. Maryland is unique. It's CDC says we are the only state in the country that has this thoroughly shared form of governance, shared between state and local governing bodies. So other states may largely be decentralized locally or centralized through state agencies. And then there's some hybrid states, but none have the kinds of statutory requirements in terms of authority, appointment, and funding that Maryland has in this shared model. We have heard, we know about the span of enormous scope that our Maryland Department of Health has as a super agency. So what are the advantages that we can leverage that super agency, because it is not only houses public health, but also Medicaid and behavioral health. We've heard presentations about our health information exchange, which has a propensity to ask and to work on behalf of public health. So the opportunity, we heard some of that from Chad today, the opportunity to really leverage more responsiveness in our health information exchange is available to us. And then lastly, HSCRC, we don't have a meeting here without hearing about the AHEAD model and how there's a promise anyway for greater resources and priorities given to population health upstream than ever before. So these are unique to Maryland's structure, and oversight. We should have added MDPCP, Maryland's primary care program, because there's real opportunities, we think, in terms of governance to strengthen some of the structures within primary care. What you're seeing here is our work groups on this chart, which I apologize if you're in the room because it's kind of blurry, but maybe you can see it. Number one was to define our scope of inquiry. So that we've done that. Number two, step number two is to identify key topics for inquiry, key topics going forward that we think that the work group really needs to rely on in order to come up with cogent recommendations on governance. And that is the current stage where we are now. So what you're going to see in the slides to follow is, instead of following the template, which asked each work group to describe your findings, we felt that findings were premature. For our work group, we have had a lot of activities, as you all have, but in terms of our findings about governance, we need to suspend that thought until we have more inquiry and more data coming in from the assessment, particularly with the key informant interviews. After that point, we'll go ahead and evaluate the data that comes in from lots of different sources and develop recommendations. So let's go forward with, this is a slide you all seen. It's a common landscape that all of the work groups have shared from FAB. It's missing something though, because in our world, what we're doing in Maryland is including along that top row of all those foundational areas, we're including behavioral health. And that's super important not to get lost in our conversation. It's statutorily mandated that we pay attention to behavioral health. And I think from a public health standpoint, you would all agree with that. So the second thing that I would say about tweaking FAB's idea here is the idea of equity is kind of weird in this. Equity is one of the several organizational capabilities. It's in that top row at the bottom. But then there's like this little shaded line at the bottom of equity. And so I think the idea is that looking at health equity should infuse all of the work in all of those clinical area, functional areas, as well as in all the capabilities. So we're onto that. And actually the template that the work groups were given really encourages that framework. Here's a slide that we threw in because we wanted to. Okay, we wanted to. And the reason is because it's to encourage us to think boldly about system change. So let's not just think about org charts when we think of governance, or let's not just think of budgets when we think of funding, or the personnel line when we think of workforce, but really dig below that first level of structural change and really look into the opportunities for making a relational change with regard to the implicit culture and the power dynamics, the relationships that exist in an organization. And how can we improve that so as to improve what you see on the top line, the policies, the practices, and the resource flow. So this is a model that comes from Senge and others. It's a landmark paper, but we just use it, keep it kind of top of mind as a reminder. Okay, so who's the we? Well, I know you all think you have the A team on your workforce, on a work group. We do have the A team here. So my comrade, Barbara, and I are really very, very pleased to be able to try to distill probably 8 months worth of very high level, intense discussions with these folks. So we're going to do our best. What we omit is on us. It's not on them. You can see on our work group, we are pleased to have a co-chair. Nina's on our work group. We're also pleased to have five current health officers on our work group. We have also 2 former health officers on our work group, including the current Deputy Secretary for Public Health on our work group. In addition, we have expertise in public health practice, in quality and health systems, in private nonprofit world, as well as in academia, including in schools of public health, as well as in University of Maryland Law School. So terrific team, and I have to do a shout out for our terrific staff. We have had great support and could not have delivered these findings. Didn't say that word. These ideas without with the help of the support of the staff. So, all right. So we were asked, okay, here's the homework assignment. What have you been doing? We've been busy. We have meetings every month. They're virtual meetings. They're lively meetings. They were 2-hour meetings, and in the interest of summer, we cut it down to an hour and a half. And then we had an hour and a half meeting last week that blew up into a 2-hour plus meeting. So very lively meetings. We have had the opportunity to reach out to other speakers as the group has indicated interest. And so here's a couple of folks that we've had really good discussions with: John Crum, HSCRC, and Mary Bearden, who is the attorney at MDH who's responsible for public health, as well as interactions with Indiana Department of Health and other speakers. So we've been taking in information from people and then also from other kinds of sources that we've had the pleasure of working with staff to accumulate. What do we know about other states as far as what they do with public health governance? What makes sense? What's been successful? What has been jettisoned? And looking at some of the peer states, as you can see, Washington, Colorado, Tennessee, and Indiana for any of their lessons learned. So, getting to the next slide, the beginning. So, the health equity and cross-cutting themes. I'll do a couple of slides on health equity and on cross-cutting themes, and then Barbara's going to speak to some of the specific areas of inquiry, not findings, areas of inquiry that we've really focused on. So health equity. Now this is going to give you an idea of how we've structured our thinking around questions, right? We don't have the answers yet, so that's why to call it findings would be premature, but we hope that some, if not all of these questions in some fashion can be elicited from our further work as well as from the interviews that are forthcoming with the assessment. So let me read these to you, and please, if you have any comments, questions, if something here is a little murky, please interrupt me, because these questions they represent literally hours of discussion, but have been crystallized into these kinds of thoughts. Okay, first and foremost, under the heading of health equity, do Maryland's public health leaders have sufficient ongoing education, organizational support, and accountability expectations to detect and act on prevailing cultural biases? So when we say leaders, first of all, we're talking state and local leaders. And leadership is not just one person in an agency. You know, there's a leadership team, senior leadership team, which really sets the tone, the culture, and the performance of the agency. And MDH being a very large agency, there's it's much larger team proportionately than you might find in the health. So when we say public health leaders, we're talking state and local. And really, what do they look like? What do they do? And what supports do they have with regard to assuring that their unit or agency is doing as much as possible to achieve health equity? Secondly, local health departments, in terms of governance, have a complicated structure. They've got some accountability to the state, not some. They have quite a bit of accountability to the state, and quite a bit of accountability to their local government, or in the case of City of Baltimore, to the city. Actually, that's a very special case that I'll talk about in a minute. In addition, there's a third entity which is statutorily required for every county, not the city, but every county, and that is a local board of health. And there's accountability responsibilities there. So our question in terms of governance is local boards of health. These are usually county commissioners or county council people, depending on the county, right? These are people who ran and were successful in a local election. I'm going to suggest that most of these people, none of these people knew when they were running for election that they were going to be named on the county board of health. Okay, that's not why they ran for office. They ran for office for very laudable purposes, but not to be on the board of health. Here they are. They won the election. They're on the county council. They're a county commissioner. Oh, you're also a board of health on the county board of health. Well, what does that mean in terms of their ability to make public health decisions? And they do make decisions that are equitable and will advance the equity in their jurisdiction. Thirdly, so here's the thing. We have local boards of health in all the counties except Baltimore City. Maryland does not have a corollary, a state board of health. Some states do and some states don't. And so an open question that we hope can get explored either by us or by others is, does it make a difference in terms of awareness and prioritization of health equity? Does it make a difference if there's a state board of health or not? I don't know, but we don't have one. And so the question is, does that make a difference? What we do have, which is the last point, is we have a recently remodeled Commission on Health Equity. And so actually we have two commissioners that serve on that commission. And so from a perspective of public health governance in Maryland, how will that commission help us move health equity forward? So what is the parallel tracks between the public health force going forward and the commission on health equity? And so that's an open question that we have. We don't have answers to, but we further inquiry. All right, so 3 more under health equity. Can and do public health agencies advance health equity when federal eligibility requirements categorically exclude some populations? This is happening. This happens by virtue of congressional act or Washington, federal action. And so there are populations who are excluded from very important federal programs by definition, usually by citizenship, right? And so that is a real factor in many jurisdictions from a local perspective. And so are the local health departments able, or is the state able? And in both instances, there have been precedent for the local health department and the state health department to step in and to take local or statewide steps in the absence of federal benefits. And so the question is there sufficient capability when the need arises at the state level and at local level for that kind of response to happen when some communities are left out of the fold? Health equity in all, that's a phrase, health equity in all. And it's a lens through which leaders in a governance position, leaders make decisions. And it's a lens that has been applied to environmental impact statements, for example, economic impact statements, health equity for all. What is the prevalence of that kind of decision making, of that kind of lens for the decision making in Maryland's public health agencies? So the idea, how frequently do agencies experience or demonstrate systematic approach, health equity and all? And lastly, let me call out, this is one for the IT people, IT data people to think about. This last bullet, are there governance or administrative barriers to cross-jurisdictional data sharing and collaborative interventions, particularly in the Baltimore metro area? So I mentioned before, Baltimore City is very unique in its public health governance, unique from anywhere else in the state. So Baltimore City has a very vibrant health department. In fact, Baltimore City's health department is the oldest continuing operating health department in the country. So it's a tremendous legacy, history in Baltimore City. Baltimore City has a commissioner. It's not a health officer. It's a commissioner, heads that agency. That commissioner is appointed and is responsible to the mayor. End of story, right? So that commissioner is not a state employee, unlike all of the other local health officers are by law. That commissioner operates in a governance structure completely independent by charter, by code, by statute, by regulation from the rest of the surrounding state. Baltimore City is hugely impactful to Maryland's overall public health data. Baltimore City's borders are porous. People go back and forth every day, and the public health concerns in Baltimore City are absolutely replicated by every single jurisdiction around Baltimore City, and in some areas beyond Baltimore City, beyond those border counties. And so what is the opportunity for local leaders to get together on data and on responses, or are there barriers because of governance, that either statutory barriers or maybe it's just practices that we could look at to better approach some more regional public health problems rather than doing it on a more sporadic basis? I use this, the example of Baltimore City. There may be other places around the state where you don't have that kind of divide as you have in terms of governance, but yet there's not the kind of data sharing across jurisdictions that would maximize the opportunity to really dig and collaboratively make an impact on a problem. Data and IT people, we are thinking maybe you came up with some of these same hints and some of these same observations, or maybe you did, but we would be happy to have an exchange to work with you on that. I'm just calling you out now because it's pretty obvious, but there's so many areas we found in looking at governance that really do bleed over into the scope of what we think are some of the other work groups. So with that, I think this is my last slide before I turn it over to Barbara. The template asks that we do our due diligence on looking at how governance is impacting or could be amended to better impact our outcomes with regard to these conditions, infant and maternal mortality, preparedness, overdoses, and COVID-19. We haven't gotten there yet. I think the work that we've done so far has been really foundational and really took a long time, but it really helped us define our scope and our boundaries such that we can tackle those kinds of cross-cutting themes in a more concise way and get some clear definition for you. So with that, I think, yeah, okay. So I'll turn this over to Barbara, and please interrupt Barbara as much as you need to.
Thanks, everybody. I got you. All right. Thank you. So continuing on, and I think it is important that we emphasize again that for us, they're the topics of inquiry. We did believe that to label it as findings would be really premature at this time. So in taking a look at the other major categories of inquiry developed over, really our January meeting, February meeting, a little bit into March. As we thought about, how the quality of public health leaders, how that impacts the governance, and then related to that is how then that impacts the organizational capability. So that's why we have leadership training and professional development up there, thinking about whether there's ongoing high quality leadership training available for senior public health officials, how's the orientation that may or may not be available impacting that, and are there some opportunities for some cross-jurisdictional exchange? Tosin had sent around an article, and maybe it was just for our work group, but it was one that reminded me of the benefit of our also looking to the literature to identify areas for inquiry and exploration. And one of those was, I've got to read this, the organizational capability in the public sector. A configurational approach identified a single core configuration of organizational attributes associated with high capability departments. Not surprisingly, it's low structural complexity and also personnel stability. So when we think about the personnel stability, that's where the leadership training and professional development comes into that. We do look forward to hearing from our colleagues in the workforce work group, identifying where there are opportunities for governance to either support, facilitate or impede workforce development, as well as for organizational capabilities. Again, how does the workforce work group view organizational capabilities and how to support them in their work? So another area for inquiry for us, the legal considerations on shared governance, and that continues with some of what Fran had mentioned earlier. With our unique structure that we have here in Maryland, are there statutory or administrative ways that we can make it more clear what the governance and really the legal structure is in Maryland? For those who aren't working in local health departments or aren't working in some components of the state health department, you might not be as familiar, but this is one of the themes that we had heard from the local health departments, identifying that it's not always clear and consistent who has what authority and when do they have that authority, and which legal team is going to support them if further action or enforcement action is needed. Also related to that, as Fran had mentioned, local health departments are often working in both the state realm, so we're looking at implementing state law, regulations, but then we also have a foot in our local jurisdictions and might have local ordinances that we are similarly responsible for. Sometimes there's overlap in actually what they can cover, but who's, when do we use which authority? So some clarity. And then what came up also was the Maryland Department of Environment. So I know a lot of people have been thinking about, oh, well, state health department. So, what's the charge for this commission? And people were thinking, oh, well, the Maryland Department of Health. Well, it turns out for local health departments that local health departments spend a considerable amount of funding, staff time, and energy implementing Maryland Department of Environment regulations and performing delegated responsibilities of the Secretary of MDE. So we wanted to make sure that's pulled in. And so that's why you'll see in the assessment that we have included the Maryland Department of Environment, or MDE. And then what doesn't show up so much on this screen, but for those who have it pulled up on their laptops or devices. So, during the COVID and past the COVID experience, there's a lot in the literature. So originally in the newspaper and the media, but now in the academic literature about, those public health authorities and how did public health authorities either help or hinder or were blocked. And so one of our areas of inquiry is, in Maryland, are there opportunities for improvement based on the experience in Maryland, based on what we've heard from other jurisdictions? Can we learn from that? Another topic of inquiry is the policy development and implementation. And when we take a look at that, the policy development, that it is one of the foundational capabilities. So Fran had showed that schematic earlier that we're all supposed to be organizing our work around. And so while these topics here aren't necessarily aimed at governance, it's more about the culture of the practices within the state health department and local health departments, but that in turn impacts the organizational capabilities. Fran gave a definition of governance, and I was reminded of what one of our former work group members, Julie Katie Ray, that she shared one of her presentations in which she noted that governance is about how power is distributed and shared, how policies are formulated, priorities set, and stakeholders made more accountable. So if we think about that, well, those are our questions for inquiry, right? I mean, it sets it up. So it's about, who, when, how, where are policies being drafted and finalized? State policy, state environmental policy, Medicaid, behavioral health that impacts local health departments, but I'd say also that also impacts our local communities. And then the final bullet there is other states have associations of health officers that have more formal roles in funding. So we're exploring, what are the pros and cons of that and what might be some alternatives for consideration here in Maryland. Another area of inquiry is the accountability and performance management. Again, in that schematic, one of the foundational capabilities. And we just don't have much information at this point about the accountability and performance management. And we're all in the public sector, and the public should be able to have a way to have assured, clear accountability. So when I'm sure many of you, read the Future of Public Health and what's been written since then. And I will say that in the American Journal of Public Health and the editorial that came out in the one issue back in March, where it was revisiting the future of public health, the good, the bad, and the ugly. the author's opinion is that, you know, there has been a lot of good since 1988. I think many of us would agree with that, I would imagine. But what was mentioned was the Public Health Accreditation Board accreditation of public health agencies, linkages between public health practice and academia, health equity, and public health investments, among other positive advancements. So thinking about that, that's some of the good that has been identified. We added to our slides here one about how might public health accreditation be used as a tool for that accountability and performance management. You know, we've heard about SIHIS, or, you know, have heard about the start of AHEAD, but what performance measures, what performance management is there? What accountability is there for those? And at the state level, and then perhaps there's a role also for the local health departments, but we need to make sure that whatever's being developed has performance management and accountability baked into it. Local boards of health, again, while they also come out in the governance side, there's also the organizational capability side, and that's what this slide is about. You know, there are minimal requirements for the state boards of health, and is that sufficient? What, you know, inferences are there regarding the composition? Fran mentioned earlier about the composition often being elected officials, not necessarily individuals with any experience, preparation that might make them feel comfortable and confident in serving in that kind of a role. And there are some other areas that we're exploring that I think we have brought up in prior presentations. And then, you know, are they helpful? Local boards of health. And there's no state board of health. Other states have a state board of health. Maybe that's an opportunity, because we've been talking about, so what, you know, all these parts that are contributing to public health. So Maryland Department of Environment, but at the Maryland Department of Health, we hear the MDPCP, you know, the AHEAD model. Was the AHEAD model really with the Department of Health? Is it with some other entity? We've heard HSCRC. So the Maryland Commission for Mark Luckner's commission. So maybe there would be a role for some overarching umbrella. So we don't know, because otherwise it's all siloed work that, you know, the secretary is working to try to make things communicate and cross-sectoral, but maybe there are some additional ways that we might consider exploring that. And also for the local boards of health, Brandon mentioned in the health equity, so I refer you back to that slide. And then academic partners, not just because we have some on our work group and because of the explicit requirement for the chairs of this group, but, you know, we're really fortunate in Maryland to have the public health academic schools, programs. I mean, even so in Frederick County, Hood College has a program now. So we have so many opportunities, I think, for the state health department probably has a better relationship, and that the schools are probably learning a lot from this relationship that they have at the state level. But for the locals, those of us outside of the Baltimore metro area, we don't have as strong of ties. That's not uniform. The work that Dr. Brewster's been doing in St. Mary's County, definitely, you know, when I look at what you've done, saying, oh, that's an academic health department. So when we look at the continuum of academic health departments along, you know, what are some of those structures, systems, activities that move one along that continuum, you know, maybe that's something for us to be exploring. And so for continued exploration, and we have remaining questions, but really, we've got as many, well, we have more questions each month we add to our question list. So, you know, we felt like well, I guess this is part of the template. We had to put something down. But you'll see, are there possible changes to public health governance that could facilitate more effective partnerships, between the local health departments, the Maryland Department of Environment. We talked about that with local health departments and Maryland Department of Health's Behavioral Health Administration, especially around clarifying authority, responsibility. It goes on. What about the quality concerns within acute or institutional care facilities? Heard that in one of the commission meetings. In another commission meeting, we heard the presentation about the hospital-based population health efforts that have been well underway and are looking to have additional injection of at least incentives, if not funding. We heard today about the Maryland PCP program, and who knows, future HSCRC grants or funding that's going to be available. So, what is the role for the state health department, for local public health agencies in all of that? And then our longest list, perhaps, is the input requested. So in case our colleagues in the other work groups have, so we do want your input. And, is this up? No, I have one more slide to go before I've got suggested conversation starters for the other work groups. But anyway, we plan to continue in the next 3 to 6 months to continue meeting and to learn from the assessment information that we receive, and then to spend some time trying to address the specific themes that the statute requires all of us to do. Oh, wait. Here, I guess it's because, I added stuff. It's on my slides. I added something on my slides. Okay, for our work group colleagues. All right, so for the funding work group, online, all right. Should there be statutory or administrative approaches to securing compensation for local health departments for the provision of MDE delegated services? For the funding work group, different county core match percents and amounts requirement exists, and some counties contribute more, some much less by statute. State funding allocation percent to a jurisdiction does not change for jurisdiction growth share of the state population. Should there, is that something that should be considered? So we wanted to share that with you for the funding work group. So now it would be much more exciting if we were having dance-offs or something, or, drum contest. But anyway, okay, so for the data and IT work group, I think I heard something earlier today, but this question is going to be phrased similarly for the other work groups. So what aspects of governance and organizational capabilities are impacting the achievement of the optimal the optimal state or situation at the state and local health department? So what aspects of governance and organizational capabilities are supporting or impeding your work group's vision from being a reality? So the same for workforce development. Again, what aspects of governance, what aspects of organizational capabilities are facilitating and or are impeding the achievement of your work group's vision? Why is that vision not a reality? And to what extent does governance and organizational capabilities impact that? So for communication, guess what I'm going to say? Communication work group. How does governance, how do the organizational competencies impact your work group's vision from being a reality? But I do have one other for the workforce development. And so it's what do we need to prepare current and future workforce? Oh, I wrote this today during the meeting earlier. So what do we need to do to prepare the current and future workforce to effectively respond and lead the potential role for local public health agencies? From what we heard from Secretary Herrera Scott, what we heard today from Chad, for the AHEAD model, when we look at local health departments and public health 3.0 role of system improvement, being the convener, the collaborator, the facilitator, what do we need workforce development wise to prepare our workforce? And then I made a note, Mina, your question about what capabilities are needed in response to what Chad presented today. What are the core capabilities needed for local health departments to support primary care providers? And also then talking about the data exchange. So I think the organizational capabilities have so much to do with what each of the organizations, what each of the work groups probably has as a vision, and governance also impacts that. And when we go back to that definition of governance, right? Let's see, what was that? It's about the power. How is the power distributed? How is the power shared? How are policies formulated, priorities set, and stakeholders held more accountable? And somebody had said, and I thought it was in one of these presentations, but maybe not, that funding, what you fund and what you choose to fund and what you choose to not fund, that's an ethical decision. And it says who we are as a public. So I don't know, that got a little off, but there we go. Questions. Fran and I would be happy to entertain your questions and look forward to each of you throwing it back to us when you have your deep dive presentations.
Great. Well, it's a great deep dive. So questions on the table here first. So let me begin on the sort of the idiosyncrasies, for example, of the boards of health, right? I mean, what is a path forward on that? Could we just, at the end of the day, we're not here necessarily to demolish all systems and to recreate. We realize that can be a difficult political process. But is there a sort of a best approach in terms of the relationships that exist between that body, however defined in specific jurisdictions, and the local health department?
I think, sure. I think we don't know. We don't have a systematic way to understand, systematic way for information and awareness for us to know that. I know that the N01, which one of those would know. So that's why the assessment is really essential. But I think there are things that can be done. I wouldn't be surprised if recommendations are more around the organizational capabilities necessarily than the governance. But we really need to understand the governance, because there's perhaps potential out there that if the governance structure were different, that maybe we'd achieve more, maybe we do achieve more than others because of the way it is. We don't know. So we would like to be able to go forward with confidence that the structure that we have is really serving us very well. But then when it comes to organizational capabilities, there is training. So the National Association for Workforce Health, they have training, they have meetings. Not so sure how many of those actually implement. So there are some things that we can do to have some consistent training across the state. Some states do that. So some state health departments, I think I've seen on their website, that state health departments are offering orientations and onboarding for members. So the law says that
unless a local government, local county or jurisdiction acts otherwise, then the Board of Health shall be the local legislative body, whether that's commissioners or. So there are two counties now that have acted differently. They've taken local action, passed an ordinance, and said, we're not doing it that way. We're going to have a board that is comprised of different. That's Howard County. And so it's interesting to look at what kinds of expertise they went out of their way to include. It doesn't shut out all of the elections. So some of them are on the board, but they brought in other kinds of expertise. And so I think I understand our position is not, we don't want to alienate. That is not what we expect. So part of the idea is, if this is the choice that the county has made, how can we bolster the capability for new people coming in to understand their role, to get support and organization, and to get the kinds of briefings that they need in order to uphold their responsibilities, which are pretty minimal. Twice a year, they need to meet. They need to advise the state if there's anything notable to advise on, and they need to evaluate the health office. There are some counties that don't do anything. Say, and some of them are diligent and do that expertise, and then a lot of them have law. So how can that? I'm not saying change the law. I mean, it's possible, but I'm not sure that's the most important thing for statutory cleanup. That's going to rile up Maryland Association of Counties. And, we're not the alien people, but how to better support them in this role. It's just kind of a footnote their role. For the states that have active boards of health, and have the public health leaders have much more credibility, and they have more opportunity to express public health needs, concerns, and interventions to that channel than some of the other counties in the state that there's just not that kind of. So anyway, that's a great question, and I think it's a really rural area to support.
Rosalie, you're on. Rosalie Bright. Okay.
Sorry, I was acting like I was unmuted. Sorry about the delay. I'm an epidemiologist, and I was watching the COVID infection, and was concerned that the local health department said that they follow what the state says. The state follows what CDC says, and it seemed like there was no consideration that the literature was saying something different a lot of the time, the scientific literature. So what do we do about this when staff are super busy trying to respond to an emergency, and yet they aren't necessarily getting the best guidance from above?
So what do we do about the, I'm gathering, Rosalie, you're asking about the question and more about like, what do we do when, about authorities? Is it about authorities? Like what do local health department authorities have that allow them to express differently than what the state health authority is saying, than what the state, and the same for the CDC, or same for the state versus CDC?
Yeah, that's part of the, that's the governance part of the question.
Roseanne, I don't know that we're understanding that part of your question. Do you mind repeating that part or rephrasing it?
Yeah. I'm having an echo. So masking has been controversial in the literature, but in the last year, it's into a consensus among well-designed public studies that respirators are very useful for course control and for protection, and especially in healthcare settings where people are more vulnerable to getting infected. Sick people go in looking for care, and other people are more vulnerable to getting infected. And respirators have also been shown to be very useful against other respiratory diseases that are emerging. And yet, our State Department websites and communications still do not mention even lower quality masks. And the local health departments don't seem to have that in any of their communications either. So what does it take to have people step out of the CDC box and say, okay, the new information is we should be having respirators in critical situations?
So, Rosalie, I think you're bringing up the point, and I'm tying it back to the topic of governance and organizational capabilities, which is what Fran and Barbara have presented on and are leading the discussion around. So if you tie it back to governance and organizational capabilities, I wonder if your topic is addressed through when we talk about the distinctions of authorities, right? Local versus state, state versus federal, and how those distinctive authorities allow for distinctive communications and distinctive decision-making when it comes to taking public health actions or making public health recommendations for their community and partners. The other topic that comes to mind, of course, is also how we communicate with our public and how we maintain those channels of communications with different partners, including our healthcare system partners.
Right, and a third, if an employee is following the literature and disagrees with the policies in their local or state organization, what can they do? Can they speak out? Can they act differently from what the official policy is?
Barbara has another comment, and then I'll pass it back to Doris.
Barbara?
Yeah, I think that's really complex what you're bringing up. I would be interested in hearing from the communications work group about this. But one of the things, when you talk specifically about masking, and if I recall correctly, at the town hall in Montgomery County, one or two persons from the public who came to speak had mentioned, I think it was something about masking. I'm anticipating that the Maryland Department of Health will be issuing shortly a reminder to healthcare facilities like they did last year that when certain metrics were met, that then organizations were required to implement masking. And so when we talk about, the masking, so I'm not quite sure whether you're just talking about that, talking about how there's been good scientific documentation of the effectiveness of a variety of types of masks and respirators, and whether it's something to be communicated to remind people, oh, these are effective, or whether you were along the lines of it should be required in healthcare facilities. Depending upon what angle you were getting at, one, I'd say the communication work group, it's a lot about that. Another is it's a little premature to be talking about masking because people aren't seeing the impact of infectious diseases. So sometimes communication is most effective when people are recognizing that it could benefit them to take those measures. So I think it's really rather complex. And you're not the first person to question whether individuals are following the best science that's out there. But again, that's where I would lean and look towards our communications colleagues. One of the topics that we already addressed is COVID, and perhaps and maybe you're on that work group, I don't know, but I'd be curious to hear what they have to say about that.
Well, I am on, on the communications group, and a lot of questions hunt back to what is the authority to say something to the public. And I'm not trying to get this group to solve the masking problem. I'm just trying to throw it out as an example. Because I'm worried about the next time we have an infectious emergency and how well we respond to it.
So I hear from the communication work group, one of their questions is, what's the authority to say something?
And I think, and I mean, to some extent, it may be tied in with what you started with, which is what's a legislative language thing about authority, right? I mean, that in essence is, and I guess, you know, maybe in the long run, as we think about recommendations, is that clear to the general public? Because if we public health people are confused by it, right? You know, is there a way of clearing this up, especially during times of emergency, right? Where, you know, there may be this uncertainty and now a skepticism from the general public, but the point's well taken. Other questions to the governance, anything from you, Jane?
No, I just, you all did an amazing. Governance is not my domain, so I'm sitting here quiet and just learning. You all did an amazing thing. Yeah.
Well, we're only halfway there. We asked a lot of questions.
Yeah, this is what you do. This is your area of expertise and you know how to do it. I just yeah. The only I did the last comment was around the workforce. And I was thinking about doulas. I'm just so thoughtful about doulas, but I know it wasn't really, it's not really about specific workforce categories. It's more about general. That last training question that you were speaking about, and what are the services that our workforce needs in general. You know, I get it, but doulas came to my mind, but I know it's cultural, out of work cultural competence and all that. I also like, Fran, your first question you had up there, your question of inquiry. I thought that was really good because I mean, just our public health departments are just so underfunded.
Right.
But I learned a lot.
Well, thank you. Thank you for bringing up doulas, you know, because I think embedded in some, we'll say workforce, but that's a fancy name for personnel decisions, right?
Yeah.
So state personnel decisions about what are the requirements for a doula or a community health worker?
Oh, okay.
Okay, and what's the pay? I mean,
Okay.
all those things really reflect a culture. They reflect
Yeah, they do.
a mental model,
Right.
and
Leadership's commitment to the work.
right, and I think that that's really right ground for digging into from a lens of health equity as well as governance.
Yeah.
So just that you said doula, and that, you know, doula is really,
Yeah.
I think that could be a linchpin around really, you look at a lot of other attributes of public health,
Right.
good and bad.
Right, you know, as you talk about the health equity, how does the health equity move forward along with the public health lens? If a department doesn't have a doula, think about that trickle down, right? Like how then are they really that doulas we know are at space, we know, you know, maternal mortality is, you know, there. So are you really concerned about that? You don't even have a person that, you know, that knows, that can help health departments or oversee that or see that program, because you don't even have back to the workforce of the states.
Well, it's also the doulas, it's community health workers, it's peer recovery specialists.
Yes,
You know,
yes,
these
all
are
of
people
those.
who have rich
mental health aides.
life experience,
Yeah.
and they can be
Right.
tremendous amount.
Right. And they're truly in that health equity lens. I mean, they represent, you know, a workforce that is very important to the population, like population health, right? To the needs that are reflected in the population health.
Right, Matt, you had a question? Well,
I just wanted to make a shameless plug. If you know anyone who can help us in Frederick, we are looking to establish a training program specifically for Black maternal health doulas.
Really?
So we
Yeah,
are looking for a partner And if perhaps the, training could be provided remotely, you know, that there was that training program set up in Baltimore County, the person.
Yeah.
And
We'd be happy, I'd be happy to share. We had, I don't know, we had about 8, and we couldn't figure out how to get them paid. We trained them. I just took on, I'm always jumping up there because I know it's so important. But it just kind of, I couldn't figure out how to pay for them. And there was just too many of them. But we have a lot of.
that's the cause.
Right. Matt?
So first, to answer your question, data technology work group, the challenge question, we are looking at interoperability and how we share data across up to the state, down back to the local partners across, as well as academic partners. So looking at how we could approach that. But wait, more to comment. Thank you for being the first. Because we didn't know what we were doing, so you set us a very high bar. I think one of the challenges that I see from general perspective is the lack of uniformity. You brought it up earlier about the lack of uniformity with local health, but even within our structure, we have OMO, we have and then who works for whom. You know, some people are state employees, some parts of people are state employees, and it makes it very, very confusing. And I'm wondering if there's a way to, look at that from the lens of how we streamline, simplify, create efficiencies, because that will also save money. And then we just went through a high performance organization training, so forgive me if I'm more technical, but there's Likert systems of care, systems of authority rather. There's the authoritative and not benevolent authoritative. There's consultative and participatory. And the highest performing organizations are consultative and participatory. And I would be curious to see if you thought a more consultative, participatory model for our health department as a state, which includes local, and if you created a structure that looked different than because we're more probably close to a malevolent authoritative or not benevolent authoritative structure than the consultative or participatory. And I'm wondering if looking at the fresh look of how will we get to be a high performance organization as a whole might be really interesting and unique and efficient, and then make it a place where people are leaders instead of leader followers. Throw that out as just a
Well, I think that's so intriguing. And it can't be imposed. You can't be opposed. You can't change a culture from whatever proposal level, whatever, to participatory. You can't say if I can do, we're going to do that. You have to grow that organically from within. And so that was, I think, one of our very first topics of inquiry was, where's the leadership development and support for today's leaders to have the kind of experience that you just had? How prevalent is that, and how deep is that in terms of people examining their own practice? So we might suggest that it needs some bolstering. So I mean that's how you grow that, right? You just can't come and say, "Hey, that's where you got to have it." So that's great.
Online on the web connection, is there any questions or comments? We have roughly 5 minutes left before closure of our meeting, but anything to the governance working group? Okay, silence on the line. So any other comments here? Well, again, an incredible tasking. It's an incredible beginning to all this. And as you stated, there was no supposition you would have all the answers at this early stage. By going first, you took a little bit off the heat off the idea that you're going to have all the answers. But you've done a great job in terms of looking at some of the bigger issues. And I think you know, as a cornerstone, right, to many other working groups, this issue of governance, of who's doing what, you know, what's the legislation say, how do we look, how do we train individuals, right? The interplay of how do we make sure that the future of public health leaders in the state and at the local health departments is assured, and that we get the right people at the right time and the right jobs doing the right thing, right? It's all about that. So thank you so much.
I would just say, it's really, Barbara and I are really grateful to our work before the right time. And we came up with a draft of this presentation, and they completely shut it down correctly as they should have. The danger free right, in order to have more fidelity to what the entire group actually bring on. So I really wanted to do a shout out. For our colleagues.
And we know you're out there online. We've seen you.
Way to go, government's working group. So in terms of announcements, as mentioned already, I'll just reiterate, our next meeting is October 3rd, 2024, the first Thursday of October, 2 to 5 p.m. here at the Prince George's County Government Building, with, again, a virtual option, although we do embrace everybody who shows up in person, and the snacks are outstanding. The upcoming North Central Regional Public Listening Session, as Shane had mentioned, in Baltimore City on October 28th. I know he just sent out a mailing to some of us regarding RSVP for that. And we talked a little bit about the other deadlines and announcements, specifically the October 21st certain write-ups for the interim final report. We'll try to schedule in a November meeting, at least to put it on the books. That's all I have. Any other announcements from the group here? What a great meeting today. It's awesome. It's very inspiring to see once again the dedication for everybody here. I now ask for a motion to adjourn our meeting. Moved by Rena, seconded by Jean. And we'll vote on adjourning the meeting, or say yes.
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 And any abstentions? Okay, well, thank you all. We're closed the meeting at 4:59 p.m.
Well done.
Thank you.